Welcome to the Hospital Medicine Unplugged podcast. We are diving deep today into a challenge that, well, it really permeates nearly every service line in the hospital. Dysphagia in the acutely ill and hospitalized patient.
Yes, and it's crucial to understand this is far more than just a nuisance symptom. To set the stage for our clinical peers listening, we should probably define this right away. Dysphagia is essentially impaired swallowing function, and that impairment critically affects the safety or maybe the efficiency of a patient's oral intake.
Right. The definition sounds straightforward, but the clinical urgency here is immense.
Absolutely.
When you look at the literature, the story is quite startling. Dysphagia is a critical, yet honestly, often under-recognized challenge in patient care.
Depending on, the specific patient population and maybe the screening methods used, the prevalence in hospitalized patients can range dramatically. We're talking from maybe 10% on a general medicine floor to upwards of 70% in some highly specialized units. It's really everywhere. Acute stroke, ICU, general geriatric floors. And that's why our goal for this deep dive, looking at the evidence you've shared, is really to unpack those specific hospital-related risk factors, the ones driving this staggering prevalence. We also need to differentiate the two main types, oropharyngeal versus esophageal dysphagia, and maybe most importantly for our listeners, outline the current evidence-based stepwise approach, the diagnostic and management approach that's essential for us as hospital physicians to lead.
Understanding why we're dedicating this time is so important, because the morbidity is just tremendous. The complications linked with hospital-acquired dysphagia are really substantial. They go far beyond simple discomfort. We're talking about things like aspiration pneumonia.
Which is a leading cause.
Exactly, a leading cause of hospital-acquired pneumonia, and therefore often a preventable complication if we're vigilant.
Precisely. And beyond just the infectious risks, you see malnutrition, dehydration, definitely prolonged length of stay, significantly increased mortality, and it follows naturally higher overall healthcare costs. The sources we looked at really hammer this home. The necessity of early identification and systematic screening just cannot be overstated if we want to mitigate these serious risks within the hospital.
Okay, that really sets the stage. Let's move right into what makes this feel like, well, an epidemic. The sheer burden of hospital-acquired dysphagia and those key risk factors we absolutely must recognize. It's vital to grasp that this isn't just a baseline condition patients walk in with. Dysphagia is actively influenced by the hospital environment itself and by our interventions. That increases both its severity and the risk of poor outcomes.
That multifactorial nature, that's what makes it such a challenge for us in hospital medicine. You've got the hospital environment contributing through critical illness itself, invasive procedures, especially thinking about endotracheal intubation and mechanical ventilation and just general deconditioning from being in the hospital for a while. But you're right, some patient populations face an especially high-risk profile. We need to flag those immediately.
The first one, and maybe the most widely recognized, has to be the patient with an acute stroke. The numbers here are, frankly, startling. Up to 78% of acute stroke patients experience some degree of dysphagia, often right away.
Yeah, and when we talk about that 78% number, it's important for our peers to understand where that comes from. Often it reflects the prevalence found using pretty rigorous bedside screening tools, or sometimes even instrumental studies in certain groups. But whether it's, say, 50% or closer to 78%, the clinical connection to adverse outcomes is immediate and profound for this group.
So it's not just a number, it means real risk.
Exactly. Acute stroke patients with dysphagia face a strongly increased risk for aspiration pneumonia, for malnutrition, and unfortunately, increased mortality. This is precisely why the American Heart Association guidelines are so firm. Early screening is mandatory for every single acute stroke patient. Immediately upon presentation, it's a core quality metric now.
Okay. And if we shift focus to the critical care setting, that's our second major high-risk population, right?
Yeah.
Centered on critical illness and what's called post-extubation dysphagia, or PED.
That's right, PED. This condition affects roughly 12 to 26% of extubated patients overall. But as those of us rotating through the ICU know, the rates climb much, much higher sometimes. You can see rates past 50% in patients who have particularly severe illness, maybe long intubation times, or multiple comorbidities during their ICU stay.
So we need to dig into the why there. What are the mechanisms behind PED?
Yeah, this is where understanding the pathophysiology is really relevant for critical care docs and for hospitalists taking over care of these patients. The mechanisms of PED are complex. For one, there's local trauma from the endotracheal tube itself. Think about prolonged cuff inflation leading to maybe some ischemia or even direct recurrent laryngeal nerve injury, which can cause vocal cord paresis.
Interesting. So it's not just a physical presence issue. There can be actual nerve damage, too.
Absolutely. And it's not just local, it's also systemic and neurological. You see altered sensorium, maybe from residual sedation or underlying sepsis-associated encephalopathy. Plus, there's the systemic neuromuscular weakness, which is tied into that whole ICU-acquired weakness syndrome. Our sources specifically highlight several independent risk factors. Predictors for dysphagia after invasive mechanical ventilation, things like prolonged duration of mechanical ventilation itself, the physical presence of a tracheostomy tube, higher disease severity scores like the APACHE-2 score, which reflects massive systemic inflammation, and even the need for renal replacement therapy. All of these factors seem to independently contribute to the risk, likely by disrupting that systemic and neuromuscular integrity needed for a coordinated swallow.
It sounds like that high APACHE-2 score isn't just a general marker of how sick the patient is, but it might point towards the systemic inflammation that directly messes with the neurological and muscular coordination for swallowing.
Precisely. If the whole body is, inflamed or shutting down, that highly coordinated sensor-motor active swallowing is often one of the first complex functions to falter.
And then thirdly, we have a core population for hospital medicine, our geriatric patients and those with dementia.
Yes. Dysphagia is highly prevalent in older adults and in those with dementia. And for these patients, it really acts as a major risk multiplier. It contributes directly to aspiration, pneumonia, and, as you'd expect, dramatically increase healthcare utilization across the board. The simple fact is that advanced age, even without an acute event like a stroke, is a powerful independent risk factor for swallowing impairment, probably due to sarcopenia, reduced physiological reserve, things like that.
So recognizing these drivers, critical illness, neurological insults like stroke and advanced age, that really allows us to be proactive, right, to set up screening protocols, which seems like the essential first step towards prevention.
Exactly. It sets the foundation.
Okay, that's a perfect transition then. Let's talk about the mechanics. We probably need a quick review of the basic physiology. Understanding how a normal swallow works helps us pinpoint where it breaks down in dysphagia.
Absolutely. Swallowing is incredibly complex. It's a coordinated sensor-motor process involving, believe it or not, over 30 muscles and multiple cranial nerves. Specifically, you're looking at V, the trigeminal, C7 facial, I-relax glossopharyngeal, X, the vagus, and 12 hypoglossal.
That's quite a network.
It really is an integrated system. Clinically, we usually break it down into 3 distinct phases. This helps because where the process fails often correlates directly with the clinical presentation. The first phase is the oral phase. This part's voluntary. It involves preparing the bolus, chewing, mixing it with saliva, shaping it, and then the tongue provides that posterior propulsion to move it back. Neural control here is mainly voluntary, mediated by those cranial nerves V and 12. Problems here often look like drooling, difficulty chewing, or trouble actually moving the food backwards in the mouth.
Okay, so that's the voluntary start. What happens next?
Next comes the pharyngeal phase. This is involuntary, often called reflexive. And this is the absolute critical moment for protecting the airway. Think of it as the body's split-second safety check. The sequence has to be perfectly timed. The velum, the soft palate, seals off the nasopharynx so food doesn't go up your nose. The larynx elevates sharply, the vocal folds adduct, they close tightly to seal the trachea, and breathing actually stops for a brief moment.
Wow, that's a lot happening almost instantly.
It is, and that rapid complex sequence is centrally coordinated. There's something called the brainstem central pattern generator, the CPG. You can think of the CPG as the swallowing software in the brainstem. It automates this whole sequence. So when diseases like stroke or maybe severe sepsis disrupt that CPG or the cranial nerves feeding information into it, that crucial airway protection gets lost. And that's when you see penetration into the airway or outright aspiration.
And the final step?
The final step is the esophageal phase. This is entirely involuntary. It starts with the relaxation of the upper esophageal sphincter, that muscle at the top of the esophagus. Then you get coordinated peristaltic contractions, those wave-like movements moving the bolus down the esophagus. And finally, it passes into the stomach through the relaxed lower esophageal sphincter. The neural control here involves the vagus nerve nuclei and that intricate network within the esophageal wall, the myenteric plexus.
Okay, so with that physiological framework in mind, how do we use it to classify dysphagia clinically?
We classify it based on the site of dysfunction, which really gives us 2 main clinical types that present quite differently. First, you have oropharyngeal dysphagia, sometimes called transfer dysphagia. This involves problems in the mouth, the pharynx, or that upper esophageal sphincter.
Right, and the typical presentation really reflects that location, doesn't it? Patients might have difficulty initiating the swallow in the first place. They might cough or choke overtly during eating or drinking, maybe nasal regurgitation, or that sensation of food just feeling stuck high up in the throat.
Exactly. And because this phase is all about immediate airway protection, its key clinical risk is that strong association with aspiration pneumonia. This is the type of dysphagia we most commonly see after a stroke, critical illness, or with neurodegenerative diseases.
Okay, so that's oropharyngeal. What's the second type?
The second type is esophageal dysphagia, sometimes called transport dysphagia. This involves dysfunction lower down in the esophageal body itself or at the lower esophageal sphincter. Patients with this type typically report a very different sensation. It's often a feeling of food sticking or obstruction or maybe discomfort in the chest, but it happens after they've successfully initiated the swallow, often several seconds later.
And this is a huge clinical distinction, I think, for hospitalists to really internalize.
Mm-hmm.
Esophageal dysphagia is actually rarely associated with aspiration. Is that right? Because the initial airway protection phase worked okay.
That's generally true, yes. The pharyngeal phase was successful. However, because it impacts getting the bolus down, it can still lead significantly to weight loss and nutritional problems if it's not treated. And clinically, this distinction immediately signals a different initial pathway. If you suspect esophageal dysphagia, you're probably thinking more towards a gastroenterology referral initially, rather than speech-language pathology.
That makes sense. So that difference, trouble starting the swallow versus food sticking after starting, is really key for guiding the initial workup and how we use our resources.
Absolutely vital.
Okay, that distinction leads us nicely into the common causes, the etiologies we typically encounter in the inpatient setting. Let's start with oropharyngeal dysphagia, focusing on those neurologic and, importantly, iatrogenic burdens we manage every day.
Right. On the neurological side, as we've mentioned, acute stroke is still the most common acute cause of dysphagia you'll see in the hospital. It just disrupts those sensorimotor control pathways, leading to that transfer difficulty and aspiration risk. But chronic neurological diseases are huge contributors to Parkinson's disease, dementia. In Parkinson's, for instance, you get slowed, rigid movements affecting both the oral and pharyngeal phases. This reduces the efficiency of propelling the bolus back and also affects airway closure timing.
And beyond the underlying diseases, what about the factors we as clinicians might be contributing, the iatrogenic causes?
Yes, these are significant and I think sometimes overlooked. Prolonged intubation and mechanical ventilation are powerful hospital-related causes. They contribute directly to PED, often due to that direct pressure injury to the recurrent laryngeal nerve causing vocal cord weakness, or maybe even subtle structural changes in the pharynx from the tube itself.
And medications. You mentioned polypharmacy earlier.
We absolutely need to be constantly aware of polypharmacy. It's just rampant in hospitalized patients, especially the elderly. Specific classes of medications can significantly worsen dysphagia. They might alter the sensorium or relax smooth muscle tone. Think about highly sedative agents, first opioids, benzodiazepines. They can blunt the pharyngeal reflex needed for airway protection. We also have to be mindful of drugs with anticholinergic properties, things like certain antipsychotics, tricyclic antidepressants, even some antiepileptics. These can decrease salivation, making bolus formation harder, and they can impair the motility of the pharynx itself, increasing the effort needed for a safe swallow.
So it might not just be the stroke itself, but maybe the 3 or 4 necessary medications we started in the ICU that are actually compounding the swallowing problem.
Exactly. It's often multifactorial. Now, when we talk about structural causes of oropharyngeal dysphagia, those are a bit less common as primary acute causes in the hospital compared to stroke or PED. But you might encounter things like a Zenker's diverticulum, that's a pouching of the pharyngeal mucosa, often leading to immediate regurgitation of undigested food or perhaps post-surgical scarring in the pharynx.
Okay, now let's shift focus down the track to esophageal dysphagia. Here, we're mainly looking at structural blockages or motility problems lower down, right?
Correct. Structural disorders are common. For example, you might see pectic strictures resulting from chronic untreated gastroesophageal reflux disease, GERD. Or, more concerningly, malignant causes like esophageal cancer or sometimes benign masses. Because these are essentially mechanical blockages, they typically present with difficulty swallowing solids first. We call that solid food dysphagia. Liquids usually pass okay until the blockage is severe.
What about inflammatory causes?
Within inflammatory conditions, one we really need to highlight is the rising recognition of eosinophilic esophagitis, or EoE. This is an immune-mediated condition, often seen in younger patients, maybe with a history of allergies or asthma. It can present acutely with dysphagia, sometimes even dramatically as a food impaction needing urgent endoscopy. EoE requires a tissue diagnosis, so you need that endoscopy with biopsies to confirm high eosinophil counts in the esophageal lining.
And lastly, what about motility disorders of the esophagus?
Right. These are functional problems where the muscle contractions are abnormal. Achalasia is a classic example that's characterized by impaired relaxation of the lower esophageal sphincter and a lack of peristalsis, or coordinated squeezing, in the main body of the esophagus. Other examples include diffuse esophageal spasm, where contractions are uncoordinated and often painful, and scleroderma, which can affect esophageal smooth muscle.
How did these motility disorders typically present differently from, say, a stricture?
That's a key point. Primary motility disorders often affect the swallowing of both solids and liquids almost equally, right from the start. This can help you differentiate them clinically from something like a simple peptic stricture, where, as we said, liquids are usually tolerated until quite late. Patients with suspected motility disorders often need highly specialized testing to confirm the diagnosis.
Understanding those distinct patterns, oropharyngeal versus esophageal, really feels like the fundamental framework for the next logical step. The systematic diagnostic evaluation that has to follow our initial bedside assessment.
Absolutely. This brings us to the core of our clinical action plan. The stepwise diagnostic evaluation. It has to be systematic, it needs to be evidence-based, and it really should integrate validated screening tools. And it all starts, of course, right there at the bedside.
So the bedside evaluation, it begins with taking a really meticulous history and observation, right? What are the key things we need to ask about or look for?
Key elements to elicit in the history include the exact onset and duration of the problem. What's the nature of the difficulty? Is it solids, liquids, or both? Are there associated symptoms? Coughing, choking. What about weight loss? That's an alarm symptom suggesting a chronic nutritional deficit.
And observation.
Observation is equally vital. You need to assess the patient's alertness level. What's their posture like? Are they slumped over? Can they follow commands? Cognitive impairment significantly bumps up the aspiration risk. Then the physical exam needs to be targeted. We assess oral motor function, lip seal, tongue movement, check their dentition. Cranial nerve integrity is crucial. And we specifically look at the strength of their voluntary cough. Can they generate a forceful cough on command?
And you mentioned voice quality earlier.
Yes, a wet or gurgly sounding voice, what we call dysphonia, after swallowing even a sip of water. That's a major red flag. It strongly suggests that material, food, or liquid has penetrated the airway or potentially been aspirated. That finding alone should trigger immediate withholding of all oral intake until further assessment.
Okay. Then we move to standardized bedside screening. This seems critical, especially for those high-risk groups like stroke and ICU patients.
Yeah.
And it needs to happen early.
Absolutely critical. We have several validated tools available. Common ones include the 3-ounce water swallow test, the Yale Swallow Protocol, the Guggins Swallowing Screen, GUSS, and the Toronto Bedside Swallowing Screening Test, or TOR-BSST. The 3-ounce water test, in particular, is quick, easy to administer, and generally has high sensitivity for detecting aspiration risk. Essentially, if the patient can drink 3 ounces of water straight without coughing or voice change, the risk of significant aspiration is lower.
Now, you mentioned earlier that up to 78% of stroke patients might experience dysphagia. Is that figure based on failing a simple bedside screen like the 3-ounce test, or does it typically require instrumental confirmation? Because those seem like very different clinical thresholds.
That's an excellent question. That high 78% figure often comes from those larger epidemiological studies that used high-sensitivity bedside screens. These screens are really designed to err on the side of caution to catch almost anyone at risk. But, and this is the crucial limitation we must emphasize, while bedside evaluation is great for risk stratification, it absolutely cannot reliably detect silent aspiration.
Silent aspiration, meaning they aspirate without any outward signs like coughing.
Exactly. Studies have shown that up to 60% of aspiration events in acute stroke patients might be silent. No visible cough, no choking reflex. They aspirate, and you wouldn't know it from just watching them. This is why failure of a bedside screening test, or even just the presence of significant high-risk factors like a severe stroke or prolonged intubation, warrants immediate action. Withholding oral intake and making a prompt referral to a speech-language pathologist, an SLP, for consideration of instrumental studies.
That need for instrumental studies is the clear next step then. Let's detail those specialized tests. How do we really differentiate oropharyngeal versus esophageal dysfunction definitively?
Okay, so the first step after a failed screen is often the formal SLP assessment. This goes beyond the quick bedside screen. The SLP performs a comprehensive clinical swallowing evaluation. They assess the underlying functional impairment in more detail, determine the initial safety level for oral intake, and provide preliminary recommendations for things like swallowing maneuvers or initial diet modifications, often pending instrumental results.
Then for really visualizing that transfer phase, that oropharyngeal part, what's the main tool?
For definitive visualization, we have the video fluoroscopic swallow study, or VFSS. You might also hear it called the modified barium swallow, or MBS. This is widely considered the gold standard for assessing oropharyngeal dysphagia. It uses fluoroscopy, like a moving X-ray, while the patient swallows different consistencies mixed with barium. It provides a dynamic, real-time view, usually in both lateral and anterior, posterior planes. You can see the whole mechanism.
And what does that let you pinpoint?
It allows us to see exactly why the patient might be aspirating or having trouble. Is it a delayed pharyngeal trigger? Is the tongue propulsion weak? Is the laryngeal elevation poor? Is there residue left behind after the swallow? The key clinical utility of the VFSS is that it accurately guides the dietary and rehabilitative strategies. You can actually trial different things in real time, like having the patient turn their head or tuck their chin, or trying thicker liquids and see immediately if it improves safety.
Okay. What about the other main instrumental test for oropharyngeal issues, a fiber optic endoscopic evaluation of swallowing, or EFA? This seems like the portable bedside option. As a hospitalist, I often see SLPs bringing the EE's cart to the ICU. What are its advantages in that busy hospital setting?
ATs offers some significant advantages, particularly portability and timing. It involves passing a thin, flexible endoscope through the nose down to the pharynx, allowing direct close-up visualization of the pharyngeal and laryngeal structures without any radiation exposure. It's excellent for detecting residue food or liquid pooling in the valleculae or piriform sinuses after the swallow. It clearly shows penetration into the laryngeal vestibule or frank aspiration after the swallow has occurred. And critically, especially post-extubation, it allows for direct assessment of vocal cord mobility. You can see if there's paresis or paralysis, which might suggest recurrent laryngeal nerve injury.
So if I have a patient who's unstable, maybe still on a ventilator, ATEs is often preferred because it's portable and gives that direct anatomical view.
Exactly. FEEs is generally preferred for patients who are unstable or difficult to transport to radiology for a VFSS. It's also very good for evaluating pharyngeal and laryngeal sensation, and it can be used to provide biofeedback during swallowing therapy right at the bedside. However, it does have a limitation. During the actual split second of the swallow reflex, the view is obscured, it whites out as the pharynx contracts around the scope. So you miss the precise mechanics of the oral phase and the exact moment of aspiration itself. For analyzing the intricate timing and quantifying residue during the swallow, VFSS remains superior.
Okay, that clarifies the oropharyngeal workup. Now let's completely shift gears. What if the patient's story points towards esophageal dysphagia, that sensation of food sticking down lower, in the chest?
Right. In that case, the esophagogastroduodenoscopy, or EGD, becomes the first-line test.
Why EGD first?
It's essential, especially if there are persistent symptoms or any alarm features like weight loss, anemia, or GI bleeding. EGD allows direct visualization of the esophageal mucosa. You can see inflammation, ulcers, strictures, masses. Crucially, it allows for biopsy sampling absolutely necessary to diagnose malignancy, or EOE. And importantly, EGD can often be therapeutic at the same time. You can dilate a benign stricture or remove an impacted piece of food right then and there. So it's primarily diagnostic and potentially therapeutic for those structural transport issues.
What if the EGD comes back normal, or we suspect something like a subtle web or a ring, or maybe a complex stricture that's hard to assess well with the endoscope?
That's when the barium esophagram becomes indicated. It's essentially a contrast X-ray study focused on the esophagus. The esophagram is also critical for detecting motility abnormalities, as it provides a functional view of how the bolus transits down the esophagus. Using specific protocols like timed barium emptying or giving a barium tablet can improve the detection of subtle bolus clearance problems seen in conditions like achalasia, even if the mucosa looked normal on EGD.
And finally, what about those really tricky cases? EGD is normal, esophagram might be subtly abnormal or also normal, but you still strongly suspect a primary motility disorder like achalasia or spasm.
That's where esophageal manometry comes in. It's the definitive test for motility disorders. Manometry involves placing a catheter with pressure sensors down the esophagus to directly measure the pressure dynamics, the strength and coordination of esophageal peristalsis, and the function of the upper and lower esophageal sphincters. It's required for the definitive diagnosis of primary motility disorders like achalasia or diffuse esophageal spasm, and it really guides the specific, often specialized medical or surgical interventions needed.
That systematic, stepwise approach, bedside screen, then SLP consult, then targeted instrumental testing based on suspected location, VFSSEEs for oropharyngeal, EGD esophagram manometry for esophageal, that seems crucial to correctly differentiate, say, a stroke causing transfer failure needing SLP rehab from a peptic stricture causing transport failure needing GI dilation.
Precisely. And that correct diagnosis and differentiation naturally leads us into discussing the management principles, which have to address both preventing complications and treating the underlying cause.
Okay, let's talk management. The general management principles seem pretty clear. The primary goal has to be preventing those bad complications, aspiration, pneumonia, malnutrition, while trying to restore safe oral intake, which is so important for quality of life.
Absolutely. And this is truly a multidisciplinary effort. Effective management absolutely requires the close collaboration of SLPs, dietitians, nursing staff, and the medical team all working together. Key non-surgical interventions often center on meticulous dietary modification. We rely heavily on things like texture-modified foods and thickened liquids.
You mentioned thickened liquids, and earlier the acronym IDDSI came up, the International Dysphagia Diet Standardization Initiative. Since this audience needs actionable info, could you briefly walk us through the clinical utility of the IDDSI framework? Why is it important?
Right. IDDSI is really important for safety and clarity. It provides a standardized terminology for food textures and liquid thickness, replacing those older, often ambiguous terms like nectar thick or honey thick or mechanical soft, which could mean different things in different facilities. IDDSI uses a continuum, a scale from level 0 thin liquids like water, up through level 4 pureed, level 5 minced and moist, level 6 soft and bite-sized, to level 7 regular food. There are also levels for liquids, level 1 slightly thick, 2 mildly thick, 3 moderately thick, and a 4 extremely thick. Clinically, this standardization is vital. It ensures that when an SLP recommends, say, level 3 liquidized food or level 2 mildly thick liquids, every staff member, nurses, dietary aides, even staff at a rehab facility the patient transfers to, understands the exact consistency required. This reduces errors and improves safety across the board. It's essentially become the universal language for safe feeding and dysphagia management.
Okay, that makes sense. Beyond modifying the diet itself, what about compensatory strategies?
Yes, these are techniques the patient learns to use to improve the safety of their swallow without actually changing the underlying swallow physiology. They compensate for the deficit. Common examples include maintaining a very upright posture, 90 degrees if possible, during meals and for at least 30 minutes afterwards. Specific postural adjustments can help too, like the chin tuck maneuver, tucking the chin down towards the chest, which helps widen the valvular space at the base of the tongue and narrows the airway entrance, offering some protection. Other maneuvers exist too, like the supraglottic swallow. And something often overlooked but critical is aggressive oral care. Keeping the mouth clean reduces the bacterial load. Why does that matter? Because aspiration of relatively clean saliva or water is far less likely to cause pneumonia than aspiration of saliva teeming with bacteria from poor oral hygiene.
That's a really practical point. And what about when oral intake just isn't safe or isn't enough to meet nutritional needs?
That's when nutritional support via enteral feeding becomes necessary. The decision often comes down to NG tube versus PEG tube, and it's usually based on the expected duration of dysphagia and the overall prognosis. Nasogastric NG tubes are generally for temporary support, typically less than 30 days. You see them often in acute stroke patients or post-extubation patients where you anticipate recovery of swallow function relatively soon. However, if dysphagia is expected to be prolonged or permanent, perhaps in the setting of advanced neurodegenerative disease like ALS or severe dementia, then a percutaneous endoscopic gastrostomy PEG tube might be considered for long-term feeding access. But, and this is crucial, this always requires very careful, thoughtful, goals of care discussions with the patient and family, especially regarding the role, benefits, and burdens of feeding tubes in advanced illness or palliative situations.
Absolutely. Now, if we tailor management by the cause for oropharyngeal dysphagia, which is often neurogenic from stroke or Parkinson's. What's the focus?
For neurogenic or pharyngeal dysphagia, the focus is squarely on those behavioral interventions. This includes swallowing exercises prescribed by the SLP, aimed at strengthening muscles or improving coordination, and those tailored texture modifications based on what the instrumental evaluation, VFSS or EE, showed was safest. We do need to be evidence-based here, though. While intensive rehabilitative exercises are the mainstay, things like the shaker exercise for super high muscle strength or the effortful swallow maneuver, we should acknowledge the current evidence regarding some newer adjunct therapies. Things like neuromuscular electrical stimulation, NMES, applied to the neck muscles, or transcranial direct current stimulation, TDCS, aimed at modulating cortical control of swallowing these, currently have mixed or inconclusive evidence from large, high-quality randomized trials. They really should only be considered as potential adjuncts within a structured behavioral therapy program led by an SLP, not as standalone treatments proven to fix the swallow.
Okay. And shifting to esophageal dysphagia, the management has to target the specific underlying cause, right?
Absolutely. Management must be directed squarely at the underlying pathology. If it's reflux esophagitis or confirmed EOE, then appropriate medical therapy like high-dose PPIs, plus potentially dietary elimination based on allergy testing or empiric trials for EOE are key. An allergist or gastroenterologist often guides this. For structural causes like peptic strictures or food impaction, endoscopic intervention is usually necessary dilation for strictures, removal of the impacted food bolus. And for the primary motility disorders like achalasia, management often requires highly specialized endoscopic therapies like pneumatic balloon dilation of the LES or the newer per-oral endoscopic myotomy, POM procedure, or sometimes surgical myotomy. Pharmacologic options for motility disorders generally have limited and temporary efficacy.
Finally, let's touch on management in those special populations. The approach needs to be really individualized and systematic here. For post-stroke patients, what's the standard?
For post-stroke patients, the mandate is clear from guidelines. Early screening for everyone, prompt SLP referral if screening fails or risk is high, and teaching appropriate compensatory maneuvers and diet modifications based on assessment. It's standard of care.
What about in the ICU or for post-extubation patients?
In the ICU setting, ideally, there should be systematic PED screening protocols in place, maybe integrated into ventilator liberation or post-extubation care bundles. Furthermore, as hospital leaders or clinicians, we need to actively address potential systemic barriers that can hinder timely evaluation, things like ensuring adequate SLP staffing, maybe even 7-day coverage, or developing standardized nursing protocols for assisting with feeding and monitoring for aspiration signs. These system issues can directly impact patient safety and increase preventable pneumonia risk.
And perhaps the most complex group, elderly, frail patients, especially those with advanced dementia.
Yes, this population often requires multimodal interventions. You might be using appropriately thickened fluids, maybe oral nutritional supplements, definitely rigorous oral care, and ongoing monitoring for any signs of trouble. But crucially, in this population, every intervention must be regularly revisited within the context of goals of care discussions. We need to ensure the proposed management aligns with the patient's overall wishes, values, and prognosis. For instance, in advanced dementia, there's pretty robust evidence suggesting that placing a PEG tube does not meaningfully prolong life, doesn't necessarily prevent aspiration pneumonia, patients can still aspirate secretions, but it does carry burdens like tube site infections and potential discomfort. So, interventions must always be weighed carefully, often focusing more on comfort, dignity, and quality of life, rather than pursuing aggressive feeding strategies that may not be beneficial.
It sounds like this holistic, integrated, evidence-based, and patient-centered approach is really the only way to effectively tackle the high morbidity and mortality tied to dysphagia in our hospitalized patients.
So wrapping this up, what does this all mean for your practice? I think our main takeaway today has to be that dysphagia isn't just a symptom to note, it's a profound marker. It signals underlying critical illness or vulnerability, and it's a strong predictor of poor outcomes, including mortality and increased resource use.
Right. And the call to action for us as hospital physicians seems very clear. We really need to take the lead within that multidisciplinary team. We are ultimately responsible for ensuring that all high-risk patients, those with acute stroke, those recently extubated, or elderly and frail patients receive systematic dysphagia evaluation. And that needs to happen immediately upon presentation, or just as critically, upon any significant change in their neurological or functional status during the hospital stay. We have to be vigilant to stop silent aspiration before it leads to pneumonia.
And maybe here's a final provocative thought for you to consider as you head back to your clinical duties. While texture modification and the use of thickened liquids are incredibly common interventions, especially in our elderly patients and those with dementia, we must continually consciously weigh the intended clinical benefit, preventing aspiration against the known risks and downsides. Those risks include poor adherence patients, often dislike the texture, and may not consume enough, leading to potential dehydration or malnutrition anyway. The clinician's focus, therefore, must always be equally balanced. We need to ensure safety, yes, but we also must prioritize optimizing the patient's quality of life, their comfort, and their dignity. It's not always an easy balance.